Hello, my name is Huy Ho, PGY2 Internal Medicine Program at HCA Florida Citrus Hospital. And today I am presenting a retrospective study assessing the relationship of statin therapy in COVID-19 patient. So our research starts with the observation that COVID-19 patient has an increased risk for thrombosis, both arterial and venous thrombosis. Additionally, the symptoms of COVID-19 patient are thought to be inflammation mediated. Statin, an anti-lipid medication, has a well-studied anti-inflammatory effect. Additionally, statin has been used for secondary prevention of myocardial infarction and strokes, which are arterial thrombosis events. So we hypothesize that statin may play a role in treating COVID-19 patients. So we retrospectively assessed about 26,000 cases of 18 years or older patients who were infected with COVID-19, and we further subdivide them into three groups based on their home medication: no statin, low to moderate intensity statin, and high intensity statin. And high intensity statin is defined as atorvastatin 40 to 80 milligram daily or rosuvastatin 20-40 milligram daily. And we assess for length of stay and inpatient mortality. So for length of stay, low to moderate intensity statin group were stayed significantly longer than no statin group, and the same with high intensity statin group. They stay longer than when compared to no statin group. However, when assessing inpatient mortality, there was no statistical significance when compared low to moderate intensity statin with no statin group. However, there was statistical significance when compared high intensity statin to no statin group. Specifically, the odds ratio was 0.76%. It means that these, when compared high intensity statin to no statin groups, there was a 24% in mortality reduction. So our interpretation of the data for the longer length of stay, when compared both low to moderate intensity statin and high intensity statin, we think that this is because these patients have comorbidities, for example, underlying CAD, diabetes, or history of stroke, heart attack. This may explain the increased length of stay in both these groups. However, when for the high intensity statin, the reduction in mortality, inpatient mortality, may be explained by the anti-inflammatory effect of statin, as well as the secondary prevention of arterial thrombosis, myocardial infarction, and stroke, which are well known in COVID-infected patients. The limitation of my study, the medication were self-reported by patient in our hospital chart. So sometimes patient may misreport or may misrepresent what they're taking at home. Secondly, we did not assess for potential reason that statin may be stopped, for instance, in elevated LFTs. And lastly, we did not assess for ICU length of stay or ventilation status. Further study, we think that a randomized controlled trial is needed to further establish a causation relationship between these groups. Additionally, we are currently studying the effect of statin post COVID hospitalization, because there was a recent study that shows an increased risk for myocardial infarction and stroke events after hospitalization from COVID-19, specifically in the first 2 weeks. That is it for my presentation. Thank you for giving me the opportunity to present my research.